Шановні колеги, пропоную розпочинати нашу зустріч
Okay,
потроху.
colleagues, let's start our meeting.
Засіданні технічної
Hello
робочої групи
at
психічного здоров'я та
this
психосоціальної
meeting
підтримки.
of the Technical Working Group
Мене
on
звати
Mental
Катерина
Health and
Кріщик, я
Psychosocial
головуюча
Support. My name is
групи
Katerina Krishik.
імені
I'm
Всесвітньої організації
the
охорони здоров'я та
co-head of
нагадую,
this group
що
on behalf of the World
національному
Health
рівні
Organization.
також
Let me remind you
керується
that on the national level,
медичним
this
корпусом та
working
функціями
group
Центру
is
психічного здоров'я.
co-headed by the
Наразі
International Medical
сьогодні
Corps and the
вітатимемося на
Coordination
нашому
Center
засіданні,
for Mental Health. We are glad to have you
проведенні
here
такої
in this
тематичної
meeting
дискусії.
dedicated to this like special topic discussion. As you know, from this new year, we've started this tradition to have different deep dives in different relevant topics in the topic of mental health and psychosocial support. And today we will have a very interesting discussion of very important topic in Ukraine, the topic related to suicide prevention. And today we will speak with you about both global and Ukrainian aspects of this topic. We will speak about what's already been implemented in Ukraine. We will listen to the global trends and recommendations where we're going, and we will also have a chance to hear from different NGOs about their experience in this area of work. So today we will hear from the international and national experts. Also, let me remind you that we have the simultaneous interpretation function, and you can choose interpretation if you need that. Also, please put your name and last name and the organization you represent in the chat so that other colleagues would also be able to contact you. And also let me remind you that in the frames of the technical working group, we kindly ask you not to use the note-taken tools based on artificial intelligence, because we create our own minutes of the meeting that we will share with you later. So thank you for your understanding. Okay, so without further ado, let's start our meeting today. And to do that, I'd like to give the floor to Claire Whitney. This is our global expert on suicide. So Claire, even before, was providing for our technical working group a webinar on this topic, and she's one of the leading experts on suicide prevention in the humanitarian context. So Claire, thank you so much for joining us these days, and today the floor is yours.
Hello, everyone, and really wonderful to see you. I see some familiar faces and lovely to connect with new colleagues as well. It's a pleasure to have the opportunity to spend some time with you, even if it's just brief, to be able to orient you to a really important guidance document on how to address the prevention and response to suicide in humanitarian settings. I'll go ahead and bring up the presentation. And look forward to a brief question and answer at the end as well. Great. So, as you all know, suicide is a very real risk and reality, unfortunately, around the world, but in particularly in settings affected by adversity and prolonged adversity. We understand, unfortunately, that with increased exposure to multiple stressors and also the prolongation of conflict, displacement, and the various changes and stressors that life might hold in times of extreme adversity, feelings of helplessness and hopelessness can increase and become quite acute. We also know that those facing particular mental health conditions and that may present with additional risk factors may be more at risk of contemplating suicide or having suicidal plans or attempts. And we understood at the global level across humanitarian settings that there really was not enough realistic, practical guidance for use in humanitarian contexts. While there is great resources out there, and I'll show you briefly what it is, it really was hard for colleagues to be able to adapt to lower resource settings or settings where we may not have enough mental health professionals available to be able to intervene in an appropriate way. And therefore, really wanted to try and learn from the best practices at the global level while really contextualizing this for humanitarian contexts to make it practical, easily accessible, and applicable, whether we're talking about what trained mental health professionals can do, what paraprofessionals can be trained to do, and how technical working groups can collaborate and coordinate and put together their efforts to try to make a difference to prevent suicide. So in terms of key documents that exist, you'll see on the left-hand side, there is a comprehensive document called Live Life that the World Health Organization developed several years back. I was actually a part of the consultation process on it, where this is a consolidation of efforts at the national level that governments, ministries put together when there was a unified effort for national suicide prevention strategies. It is a terrific resource, and I encourage everyone to have a look at it. But you'll see that the primary audience is specifically government officials. That being said, because the product was so grounded in global research, evidence, and best practices, the IASC guidance note actually follows the same organization of content, so that if you're looking at the two documents side by side, you can see how it's presented if you're thinking about it from a broader strategic level at the national level, as well as how to read it and understand it best at the local level, or in particular, if you're working in communities that are particularly low resource in terms of the number of mental health professionals. We also have, of course, the Mental Health and Psychosocial Support Minimum Service Package, which does consolidate a number of these resources. But just to point out a few more, there's also a WHO Preventing Suicide Community Engagement Toolkit. We pulled some best practices from that as well. There's an IFRC training online on suicide prevention, and also in the EQUIP tools and training, there is a specific brief training on addressing suicide. And so we just wanted to let you all know that within the contents of the IASC document, you'll see reference to numerous other resources that are available with the links, so that you can just reference the guidance note itself, but there are numerous helpful resources that are also available. And briefly to also share, we do have some relevant translations in Ukrainian. So hopefully you all have seen the Ukrainian translation of the IASC guidance note, as well as the MSP, I'm sure, and other key awareness raising and advocacy resources. So just to tell you briefly how the IASC guidance note was developed and organized, so myself, as a part of International Medical Corps, as well as Inka Weisbecker from the World Health Organization, we co-chaired a thematic working group at the global level that included other key mental health professionals at the HQ level, but we also included key colleagues from country levels that were already working quite deeply on suicide prevention and response. And what's really interesting is in Bangladesh, the mhPSS Technical Working Group has had a long-standing task force specific for suicide prevention because this topic, this problem was so significant that there were actually efforts to bring just, maybe 5 or 6 of the members of the wider mhPSS Technical Working Group to really think about how to address this from an interagency perspective at the local level. We also had someone working closely in Iraq. And so just to say, the collaboration on this was really a nice collection of experts that had differing degrees also in terms of clinical practice, working with individuals on suicide prevention, and then that broader coordination level. So in terms of and then just to say, we finalized this in 2022, and it went for interagency approval and validation to become a proper IASC document. What you'll see throughout the document is it's divided into the sections that you see here, where there are as much evidence-based or evidence-informed or well-documented best practices according to the different thematic areas. And then we also include examples from humanitarian settings that briefly capture some of these key best practices. So again, we really tried to make it as relatable to ongoing humanitarian emergency contexts. This is where it's similar but different to the Live Life document, which is looking at more stable, developed countries that were working on something at the national level. Here we're saying, okay, even if we're just focusing on local levels and more preliminary efforts, here are some successes. The document is divided first. It starts with interagency coordination and assessment, really talks about the best practices of coordination. And you all are very lucky, as I say every time I talk to Ukrainian colleagues. I've been in this field for over 20 years. I have never seen such a well-organized, committed technical working group globally as I have with Ukraine. You all have such strong commitment and terrific coordination and collaboration. So you could have written this section yourself, I'm sure. But it really speaks to the importance when addressing a topic like suicide, especially when it is sensitive, stigmatized, complex, and requires coordination across so many different actors and experts or paraprofessionals under supervision to be able to respond, to plan, to advocate. It also includes best practices on assessment, really wanting to understand within the country context you work, what are the trends that are seen in terms of demographics, in terms of methods, in terms of contributing factors and risks. Are there formal or informal suicide prevention policies in place, these types of things. The next part goes into what should be considered essential components for any country humanitarian context-based suicide prevention program. So it ranges from awareness raising and advocacy to surveillance, which it can be quite complex to set up, but really crucial to understand how we are monitoring the suicidal cases and potential responses. It includes staff and volunteer care and well-being. We know, with communities affected by adversity that are also working on topics like this, it's quite heavy, and we need to maximize self-care. And then also looking at the core competencies involved. And then the third section is looking at suicide prevention and intervention approaches, how to reduce access to means of suicide, responsible communication on this, capacity building best practices for frontline workers and gatekeepers, so, teachers or community members, religious figures. And then how to provide mental health care as a part of general health care, which you are all experts on as well. And finally, focusing on building life skills among young people, because we do know that young people are particularly at risk, specifically adolescents. So I'm not going to go in depth. I'll share the full presentation with you, but I understand time is limited. But, this just kind of goes through all of the different ways that technical working groups can work together to really try to focus in on the problem of suicide, whether it is a part of the TOR of the technical working group, whether there is an interest in developing a task force associated with the working group. There's really so much that can be done when efforts are put together, thinking about prevention, intervention, and postvention. So, postvention meaning, if a suicide has taken place, how to support family members, friends, and communities that might have been impacted, which oftentimes, unfortunately, may get neglected. So really just thinking about all of the different aspects of how key actors can work together. And with assessment, you'll see there are a few pages within it that actually give very specific questions that can be asked as a part of a wider assessment. Again, trying to understand trends, policies, strategies, existing efforts, gaps, and ultimately really helping to focus for a more nuanced approach. And then in terms of the essential components for all programs, I was kind of sharing, I don't want to spend too much time on this, but you'll see when you go through the document, there's really a lot of best practices and links to additional resources on awareness raising and advocacy messages as well, for how to sensitively and appropriately talk about it. That really does matter, especially when we're seeing trends or what we call copycat incidences, and really how we all play a role really in how we're best talking about it appropriately, and then how we're taking note of those trends and really trying to reinforce the competencies and well-being of those that are responding. In terms of guidance and best practices, this is just going to be quite brief again because this is more of an orientation to the document rather than a full training on it. But what you'll see is we have included best practices, understanding that every single person can play a really important role in preventing suicide. We know what psychologists, psychiatrists, well-trained social workers can do. What's really important is to understand what paraprofessional mental health workers can do when they are trained and supervised properly, and thinking outside the box about who can play a role. So it goes through various different types of frontline workers and gatekeepers, best practices to keep in mind. But really, when we might feel overwhelmed and a bit intimidated that there aren't enough trained mental health professionals to prevent and to respond, to really widen our thinking on this and how to engage strategically many different actors in the community that can play a really large role. You're familiar very well with a lot of key resources, but just as a reminder, mhGAP, both the IG and the HIG include modules on suicide that, of course, are evidence-based and best practices for capacity strengthening. As I mentioned before, equip, and you'll have this document so you can click on these links and familiarize yourselves with these training packages available. Just to say as well, International Medical Corps has a risk assessment and safety planning tool. This is something that would be interesting to discuss and reflect on for organizations that have mental health professionals working on this, is actually looking at, how are they trained and oriented to assess what types of questions, how are the questions asked sensitively, how is it documented, and how then does this lead to a responsible safety planning tool. UNHCR also came out with a suicide prevention toolkit, which is, their primary audience is, of course, internal, but it is a publicly available tool, just like IMC's is, that also is looking at, how community health workers and others can really be trained on this without having to be an expert. Just a brief point here. One of the most evidence-based ways of preventing suicide is reducing access to means of suicide. In communities, for example, where pesticide is the more commonly used method, efforts at local, regional, national levels to reduce access to pesticide actually concretely result in less suicide. So this is where the trend analysis and understanding the means and patterns within Ukraine can also shed some light on what can be done to reduce means and really understanding a nuanced response. So I know we went through this quickly, but I just wanted to make sure you are all familiar with the document itself, with the Ukrainian translation, with how it's organized and all of the rich guidance and technical resources linked within them that is available to you, and how it can be used, whether you're thinking about this from the collective technical working group perspective, or you within your organization, what you can do with your mental health colleagues and teams, clinical staff, paraprofessionals, how this could be used maybe even more so in, harder to reach areas where there may not be mental health professionals, and looking still at what can be done, and how as well to support one another and learn from these efforts, because it is such a crucial topic to invest in and make a difference in. I'm not sure if there are any, is there time for any questions, or shall we just conclude?
Так, я думаю, що в нас є простір
Yes,
для
I
питань,
think
щоб
that we have some
вихід,
time for questions. Colleagues, do you have any questions to clear? While colleagues are still thinking about it, I want to thank you for this informative presentation. Colleagues, thank you so much. And Claire, thank you so much that you joined us. I understand that you have a lot of work, so we really appreciate that you joined us. Do you have any questions, colleagues? I have a question. Yes. Thank you so much, Claire, for sharing this huge number of valuable resources, and that you highlighted the work of the technical working group in Ukraine, that it has really unique experience that it gladly shares with other countries. We can see that in this guide, awareness raising in suicide hugely matters. And what we can see working in different regions, especially in small and remote areas, we can see that people in general are scared to even talk about it, to bring up this topic. Is there any recommendation on how to encourage people participate in such discussions, in different activities related to this topic, and discuss this problem that's big in Ukraine?
Thank you, Yulia. That's a really important question. And very interestingly, this came up the last time I connected with Ukrainian colleagues in particular, which goes to show that it's still a vital topic to discuss. One of the most important points to convey when approaching people with a discussion is to say that, yes, it can be scary to talk about it. It can make us feel uncomfortable because we're working with someone that it's one of the worst things, right? Is someone that has lost hope to such a degree that they're really truly thinking about ending their lives. It is a deeply saddening, troubling reality, and it makes us feel uncomfortable. And I think our proclivity, our nature is to say, oh goodness, I don't want to say or do anything that might make this worse. The most important thing for everyone to know when you talk with other colleagues is asking about having suicidal thoughts does not make someone more likely to think about it or more likely to act on it. And this is a common misunderstanding in communities around the world. And it's okay that it's a common misunderstanding, but that's why it's also so important to do the awareness raising. Because for people that are thinking about it, it actually can feel like a big relief if someone asks, because they'll usually be pretty honest and say, yes, yes, I have, even though it is hard to do. But because it's also filled with so much stigma, people are usually reluctant to want to share it. So that's why it's so important, whether we're talking about a conversation at a community level, or even how, if someone is talking to a friend, right? It's important to ask that, because it's not going to increase their risk of thinking about it. If they're already thinking about it, it's on their mind, and it can have the reverse impact of feeling relieved to not carry a secret and to be able to talk about it. And then the most crucial point, of course, is making that referral to someone that is well trained to be able to intervene. There's so much stigma and also lack of understanding around the facts and what we do know about suicidality, that the awareness raising is so crucial, because it's through identifying people that have those thoughts or those plans that we help save the life. If we don't ask and we don't know, then it could be too late.
Дякую велике, Клер.
Thank you so much, Claire. And 2 more questions. Olena, the floor is yours.
Раз, давайте, може, пані Ірина тоді поки.
Maybe Irina, while Olena is quiet, we can give the floor to Irina. I'm ready. Claire, thank you so much for this very informative and serious presentation. You shared very important resources with us. So can I ask you one more question? So very often in the communities, we face comorbid problems like substance use and suicidal risks, which right away go up with substance use. Especially it's related to the teenagers, and when they reach the critical level of intoxication, very often they make some very impulsive actions because they are intoxicated with substances. Maybe you know about some scientific guidelines, like resources, anything, any mechanisms to work with the community, how to counter that? Thank you.
Thank you. That is a really good question and a really important observation. And it is true that, suicidal thoughts and planning, or, how it can come to someone to think about it, can be influenced by so many factors. It can be the stressors around them, their own mental health, but also, yes, the use of substances definitely poses as a very serious risk factor. And it does make it more complicated to know how to intervene, especially because, suicidality, it can be something that someone is facing for several days or weeks or months at a time, but it can also be an impulsive behavior in a moment when someone feels like completely lost and hopeless. And the spontaneous combination of having those thoughts and taking drugs, for example, or alcohol to a level of extreme intoxication is a very crucial risk. And I think this is where there need to be efforts across disciplines and across organizations to try and tackle this separately, because there's not really one perfect approach specific to this problem, but it's more, how do you work on the suicide prevention strategies and wellness promotion more broadly? How do we address substance use in adolescence? And then how can those efforts be kind of complementarity, right? You want to think about across disciplines. And this is where it also goes beyond MHPSS. And at the beginning, and when you read the guidance document, it really talks about an intersectoral response. And so it does depend on the level of effort that's going into addressing substance use in adolescents, as well as the suicide prevention strategies. Now, when you're talking about an individual clinician, so if you've got a trained psychologist or psychiatrist, then you're in a more fortunate situation where the assessment can go more in depth about the mental health, any potential mental health condition, and the details around the substance use and the education that can be given to an individual about the dangers of engaging with substances when having suicidal thoughts. But at a broader kind of community level, there really need to be coordinated efforts across disciplines. There are definitely interventions to reduce the use of substances in adolescents, and even adaptations of certain interventions that you all know well, like PM+. There's an adaptation for alcohol reduction, but we also have, for example, TreatNet. It has been rolled out in parts of Ukraine, which is more of a family plus adolescent approach for dealing with substance use in adolescence and how to reduce that effectively. Really good question. For the sake of time, I think I'll stop there, but it does really require coordinated efforts to be able to effectively address this.
Дякую дуже, Клер. Дійсно, це
Thank you,
питання
Claire.
дуже важливе.
This is a really important question. I want to point. Thank you so much, Irina, for bringing up this question. Unfortunately, we do notice such trends in Ukraine as well, and we really want to thank Claire for answering this question. We will research this topic and we will share the materials with you if we find something. Olena, we can see that you have a raised hand. Is it a mistaken hand, or do you have a question? It seems like it was a mistaken raised hand. Okay. Thank you so much, Claire. Thank you for taking your time to join us. Thank you so much for sharing highly valuable recommendations, guidelines in this guidance note. We will also share and promote this guidance note, ISC guidance note, and it was very nice to hear about all of that from you and to learn about your insights on this topic. So thank you for joining us. And now let's move on to our next speaker so that we would have a chance to discuss and get a bit closer to Ukrainian context. I'd like to give the floor to Olena Bidovanets, the coordinator of mental health and the chief specialist on hepatitis and opioid addictions of PHC, Ministry of Health. Could you share some updates on what preventative measures we have, and in general, could you share the current status on behalf of the Public Health Center? Olena, thank you for joining us. The floor is yours. Greetings, Katarina. Just a moment, let me share my presentation.
Скажіть, будь ласка, чи видно?
Can you see it well? Yes, we can see it well. Okay. So today I will talk about the implementation of the suicide prevention activities, which is done by Public Health Center. So let me share some statistics about the prevalence. More than 720,000 people die because of suicide annually. This is the updated data because earlier we used 700,000, but we can see the increasing trend. And this is the statistics from the WHO. We can say that for each suicide which was done, there are a few attempts. So the number of people who attempt to do it is way bigger. And this is the fourth reason of death for people of 15 to 20. And the data on suicide is very underestimated. Then again, first of all, it's due to the fact that there are 4 times more attempts than finished suicides. The system of documentation and registration is not perfect. We'll talk about it later. And there is a high level of stigmatization. Previous participants also spoke about it, and it is very difficult to identify whether it was due to the substance use or injury, and it's important to say that the level of suicides among males is higher in all the countries, and although women take more attempts to suicide, but the finished suicides are more frequent among men. And in this slide, we can see that Ukraine is on the 14th place of deaths due to suicide, and this is the data of the WHO. If we speak about Ukraine, Ukraine has the high number of suicide cases. In 2021, officially 5,914 suicides were registered by state statistics. In Ukraine, we don't have the reliable data system on the prevalence of suicides. Here we're speaking about ideations, attempts, and finished suicides. And why do I speak about 2021? Because the analysis finishes and the state statistics doesn't give any data after 2021, since in 2022 in Ukraine we had the escalation of the war with Russia, and this data wasn't collected. So if we analyze all the received data from the state statistics, well, first of all, men do 4 to 5 times more often suicide than women. Mostly it's done in the age group 15-29, more in the rural area. The leader out of all the means is hanging, and men choose shooting themselves and women poisoning mostly. Why I highlighted a lot of that in yellow? Because Ukraine has the war with Russia right now, and the access to gun and weapon has increased. So we can assume that the number of suicides by gun has increased and may increase. And also jumping from some heights is also very frequent in the cities, and pesticides or drowning is very frequent in the rural areas. Here the WHO and the state statistics and the Unified Registry of Investigations that we received from the General Prosecutor's Office, you can see also 667 cases. We don't have the unified data, but this number 5,667 is lower than in 2021, but we need to understand that we have the occupied territories, and of course the data collection during the martial law is not perfect. So of course it's not something that we can truly rely on. And this slide is also very interesting because we can compare the reasons of death in the year of 2000 and year 2023. So you can see different data resources from State Statistics Office, and also there is the death of the tuberculosis, HIV, and suicide and car accidents. And as you can see, the death due to the suicides is higher by numbers than all the other reasons. And actually, the stigmatization of suicides is so high that often it's quieted out and silenced, and critical situations are often underestimated. So what are the vulnerable population groups? Taking into account the situation that we have, it's veterans, children, IDPs, military service members, and people who survived tortures and captivity. It's also the State Statistics Office data and the Unified Registry. The data doesn't match, so obviously we cannot believe that in 2024 there were only 11 suicides among children, because we often hear about such cases which became more frequent among children. And then again, it proves that it's really important to develop an effective registration system. So what are the main conclusions about the analysis of the current situation in Ukraine? There is no surveillance system, there is no registry of suicidal attempts and non-finished suicides. They overtake other reasons of death like car accidents, tuberculosis, and HIV. It's impossible to collect data about suicides during martial law, and sometimes other reasons of deaths are put into the record like car accident or poisoning. And suicide is a politically significant problem, and it's put into the action plan for 2024-2026 and in the concept of mental health of Ukraine. And there is the order and task from Dmytro Shmyhal, Prime Minister of Ukraine, to think about the suicidal prevention means. And also it's important to say that the suicide prevention is one of the main responsibilities in terms of the European accession. So what are the key interventions and elements? They are based on the WHO recommendations Live Life, that is the implementation of the effective epidemiological surveillance system and the system of data collection, limitation of the lethal means, and also awareness raising on suicide via mass media and the development of different competencies and identification of people with mental health disorders. The main principles of the implementation of the interventions, as an example of the PHC, the analysis of the current situation based on the data that we collected from the Office of the General Prosecutor, State Statistics Office, we've managed to develop the concept on suicidal prevention. Multi-sectoral cooperation looks this way. So we also have to have the national workshop on the development of actions to prevent suicides. At this workshop, we want to work on some cases and speak about the barriers and gaps in the area of suicide prevention. We want to understand what's already done and what can be improved. Next is awareness raising and advocacy campaign, September 10 and March 1st during the mental health specific days. Then the next point is capacity building and funding. All these processes are interrelated, and it's important for all the specialists to talk more about suicides and the role of different institutions in the suicide prevention. And the next component is monitoring and assessment. It's an important component of the epidemiological surveillance, and in our technical and we're still working on the technical guidance right now. And it's important to say that we already have the technical group working on the technical standard of suicidal prevention, and we're starting to work on this standard of medical aid in this case. So what is the primary action plan? To improve the registry system, to analyze the international practice on suicidal prevention, to strengthen the leadership, coordinate effort, to also take measures for early identification and to provide care for people with suicidal behavior. It's about standards and what previous speaker has said about the importance of mhGAP and to continue the trainings of all the doctors and specialists. The next point is important is the activities which are raising awareness and on suicide, like this communication with the journalists is important, especially in the times when social media and other information platforms are important. And the final slide is all the key stakeholders. I'm sure that we didn't put all of them here, but this final slide is about how the topic of suicide is not just about one institution, but it's also the cross-cutting issue, and it's related to truly a lot of participants, and the responsibility on suicide prevention is on each of us. So that's it. I tried to quickly finish everything. The presentation is big. You can dive deep into it once you get it. Now feel free to ask the questions. Thank you so much, Olena. Really, we can see that the state does a lot, but we still have a long way ahead of us in this regard. I could see a question in the chat about the programs aimed at supporting teenagers, but I want to ask a broader question, not just about the programs, but in general about the problem of suicide among teenagers. Are there any work results in this field? What's being implemented? What is the situation with this problem? Because no conversation about suicide goes without teenagers topic. I agree with you. Last year, the Coordination Center for Mental Health under the Cabinet of Ministers of Ukraine had 4 roundtable discussions dedicated to suicidal prevention among teenagers. They were very fruitful. It's about some activities related to this topic of suicide among teenagers. About statistics, I've shown you everything that we have. We may assume that there are a lot of such cases besides in social media and online. We can see more and more articles about suicides of teenagers, but we don't have the statistics. It's not that I don't want to share it, I simply don't have the statistics. About the measures which are taken, I can say that on each level, we partly analyzed it and we during our national workshop, one of the cases was dedicated to teenagers. And when I say about the self-harm behavior at school and what we can do about it, like what steps need to be taken at school, so we conducted the analysis and we understood that there are some programs which are being implemented by the Ministry of Education, Ministry of Youth and Sports, but I am using general description because we didn't dive deep into the topic of suicide among teenagers. Thank you, Olena. And also I'd like to comment here because both of our speakers mentioned today different tools, in particular the WHO tools and the global tools on suicide prevention. So here it's important to highlight and share one more update, that most tools are already translated into Ukrainian and we share all of them with you in the chat, but also the other tools like Live Life and Community tool related to suicide prevention is being translated into Ukrainian, and shortly we'll share it with you and we'll inform you on that. So let me predict the question, and I've just answered it. So maybe there are some questions or comments to Olena's speech. Seems like there are no questions or comments, so thank you so much, Olena. Really, this topic is so important and we'll be looking forward to see more results in building the system of response and prevention of suicide. We do hope that we'll manage to overcome this problem together, so thank you so much for taking your time to join us. Today, we will share your presentation with all the colleagues so that they would have a chance to look through it in more detail, because it has a lot of valuable information, which will probably interest a lot of people since it's probably new for a lot of them. Thank you, Olena. And right now, I would like maybe to complement to the presentations that we've already listened to about the actions taken on the area of in the area of public health. I'd like to stop on the tool that was mentioned today by both speakers. That's mhGAP. And let's speak about how this tool's implementation in Ukraine can help prevent or respond to suicides. And to speak about this component, this case, I'd like to give the floor to Mariia Pirohova. She's a trainer and supervisor of mhGAP in Ukraine, and she is also a family doctor or general practitioner. So we will hear the double perspective. On the one hand, the person has the expertise in mhGAP, and on the other hand, as a general practitioner. Mariia, the floor is yours. Greetings, colleagues. Good to join this conversation today, so let me share some information with you. The topic of suicides and self-harm is the topic of primary health care. And here in the presentation, you can see that some information is duplicated. I want to thank Olena for updating the data. For me, it's really important as a trainer because it's nice to share updated information. Really, in the world, approximately 720,000 people die due to the suicide, and 90% of the cases are related to mental health disorders. That's why this topic is a separate module in mhGAP. And in 2019, when the implementation of the program started, our country was on the 14th place in the world of it had the highest level of the suicide. That's why self-harm and suicide module was identified as the priority module and was included into the offline training part 1 and then to the second part of the online course on the Academy of NHSU platform. And the screening on suicidal risk is mandatory in every part of mhGAP. Feel free to scan the QR code to see the NHSU Academy platform and to join this course to expand your knowledge a bit. So from the perspective of GP, family doctor, I can say that the topic of suicide and questions about suicide are the most uncomfortable and the most stigmatized. Still, a lot of people think that when we ask a person about suicidal thoughts, we can somehow push the person to do suicide. And as Claire said it today, it's a myth. Actually, it doesn't really matter if you're like a GP or a nurse. If the health worker asks about suicidal thoughts, this way the health worker prevents suicide. The primary healthcare specialist may support providing the hotline contacts or may support finding the supportive environment or may help with the action plan when the person is in the darkest corner of his or her life. There are actually a lot of cases when the person asks for help due to the suicidal thoughts, but in this case, the person goes to a psychiatrist or psychotherapist. On the primary healthcare level, the person doesn't usually speak about the suicidal thoughts or plans even to do the suicide until you directly ask about it. After I finished my first mhGAP training as a doctor, it was at first very uncomfortable for me to ask this question. It was a very difficult way because to each question like that, it was like as if I poured cold water on my head because it took time. But over time, you build this habit and it becomes a routine. Just like I comfortably ask about some allergic reactions or taking medications. And I can see that these questions save lives. Next slide, please. Thank you. You can see it here that in the mhGAP guide, there are 3 protocols of the management depending on the risk assessment. That's like the assessment of self-harm and then direct self-harm and the risk of suicide or self-harm. The protocols have different interventions, but what they have in common is active psychosocial support, follow-up support and the consultation with the mental health specialist. Not all the clients will have the access to the mental health specialist, but the first 2 points can be provided by the primary healthcare worker. For example, recently I had a patient, she is 21, and she said about the constant fatigue. So I suspected she had depression, and I asked about suicide. And turns out that over the last 6 months, the girl has regular thoughts on suicide. She didn't ask for any health care about it. Even more than that, at teenage period, the self-harm behavior was usual for her. Nobody knew about it since she never spoke about it and never received care about it. She felt ashamed to talk about it, just like she feels ashamed to talk about suicidal thoughts. Or another case, teenage 14 came with her mother for an appointment and the mother complained that the child can sleep. Later, I invited the girl to talk without her mother, and when she was without her mother, she said that she often cuts herself a little bit and nobody knows about it. And it's important because people often do not say about it. In both cases, like psychoeducation was provided, psychosocial interventions were provided, and they were supportive until the moment when they could get the support from a psychiatrist. As a trainer, I conduct supervisions after mhGAP, and a lot of my colleagues share experience which starts from the words. A patient came to me with the complaints on the constant fatigue and lack of energy, and when I asked the different questions, turns out that like she had suicidal thoughts. There are a lot of stories like that, but what they have in common, people won't share it with you if you don't ask questions. Next slide. That's really important to build the skills of effective communications. Suicidal and screening and self-harm screening is important. That is the mandatory part of the primary healthcare workers' responsibilities. But also it's important to know what's the attitude of the healthcare worker to suicide, because sometimes we like unintentionally show it, because here on the slide you can see do's and don'ts that you have to consider in communication with the person when you touch upon the suicide topic. So if you have some doubts on what you can say, what you cannot say, you can always ask for clarifications. Katerina or her colleague will put the email that you can write your questions on, and I will not take any more of your time. I will gladly answer your questions if you have them. Thank you so much, Mariia, for such an interesting presentation, sharing what mhGAP initiative is doing in Ukraine. If I may, can I ask you about the experience of the training on this module for the primary healthcare workers? I mean, what challenges do you face in training primary healthcare workers on this module? What are the challenges? What are the achievements in this regard? How effective is this module to shift the perception of this problem by the specialists? So could you share a few more words about how the training on this module goes? What are the challenges there and some points? Thank you for your question. Actually, the topic of suicide and self-harm, even among the primary healthcare workers who come to mhGAP training, it is quite tabooed. At first, it causes a lot of resistance. People find it like scary to talk about it. So we dedicate the whole training day. Well, first of all, the topic is very relevant, and like we teach how to assess, but then we speak what questions can be asked, how you can formulate these questions, and then we hand them out different memos so that they would have them at hand when they take their first steps, when they are still really worried, so that they would have something to rely on. These questions are in the handout materials and in the guidebook, and thanks to the supervision sessions, we can always go back to these questions and polish off some skills if they weren't built enough. Thank you so much, Mariia. Yes, it's really important here to have supervisions and to discuss how all of that is being implemented in practice. That's why thank you so much for that. I can see one more question from Inna, that whether psychologists can take mhGAP. So psychologists also show interest to mhGAP protocols. Yes, psychologists can also take mhGAP training, but in 2025, the target audience for mhGAP trainings is the primary healthcare workers. I mean, the general practitioners, pediatricians, therapists, nurses. So you can submit your application to have the training, there is a link to do that. I'll share it after my speech. And while you're waiting, you can take the online course on the NHSU Academy platform to have the general understanding of what it's all about. There are a lot of theoretical materials, and you can also submit your application there to take an offline training where we will be happy to see you.
Пані Катерина, не чутно.
Katerina, we cannot hear you. Thank you. Thank you, Maria. I wanted to highlight that really this component is available online in the online course, and it's available for everyone, right? So anyone can register for that online course. Exactly. So there are even 2 parts. So we gladly invite you to both of them. Thank you, Maria, and Irina will send the link in the chat to that online course so that anyone who wants to take it, and we will take it, and also the link to the guidebook, because some specialists will also benefit from just looking through this information in the guidebook itself, and they can understand a lot after they read this information. So thank you, Maria. And I can see no more questions in the chat, but it was so good to have you here. Thank you for sharing your experience. Now I'd like to give the floor to Julia so that she would introduce our next speaker. Julia, the floor is yours. Thank you, Katerina. Thank you, Maria, for such presentation where you highlighted the importance of the primary healthcare workers in the work with these cases where there are risks of suicides. And you also mentioned that when doctors identify such cases, they can refer the patients to the hotlines for patients to get the necessary care. That's exactly why I will gladly introduce our next speaker, Paul Niland. He's the founder of the hotline Lifeline Ukraine. I'm sure a lot of people know about it. So, Paul, the floor is yours. Irina, could you please share the presentation? Thank you.
Julia, thank you very much for the introduction, and Katerina, it's nice to see you again, and when I scrolled through to see who's participating, it's nice to see a few friendly faces amongst the audience here. I want to say just at the very beginning, this is unscripted, this is not my presentation, but I'm frustrated and angry actually right now. Julia knows about this, that I've had technical difficulties and I missed big chunks of the first part of this meeting because I'm going to tell you why. I have been involved in suicide prevention in Ukraine for more than 6 years. And this right now, this is the most intense and professional qualified discussion on suicide prevention that I have participated in outside of my own office in those 6 years. So when I've just been able to dip in and hear Claire talking about busting myths, like, for example, the myth that if you talk about suicide with somebody, potentially you might increase their potential to think about that, it's nonsense. And I'm so glad to see that being covered. It was so good as well to see Olena from the Centro Hromadske Zdrowia talking on many of the same subjects that I've been talking about for years. So that's my introduction. The photo there is me. That's who I am. I'm the founder of Lifeline Ukraine. Будь ласка, наступна slide. What is Lifeline Ukraine? Since the 14th of October 2019, which used to be Defenders Day before it was changed, we are an emergency service in Ukraine. You have the fire, the police, the ambulance, 24 hours a day, 7 days a week. You need, as a matter of urgency, support and help. Since the 14th of October 2019, Lifeline Ukraine is there as well. And we are there to help people who are dealing with emotional crises or psychological distress and contemplating ending their own lives. And one thing that I want you to also understand is that having a suicide prevention hotline in any other country in the world is the most normal thing. right? If we're in the United States, where Claire was talking from earlier on, they have their national suicide prevention hotline. I know the people who run it. They recently changed so that their short dial number is the same as the emergency services. It's not 911, it's 988. They're normal everywhere. Ukraine never had one. And when I was first asked to do this, one of the first lessons that I learned, and this again plays into what the earlier speakers were saying as well, suicide is not only one of the leading causes of death. That was a statistic from the last presentation, 700,000 lives lost to suicide per year. It's also one of the most preventable causes of death. Take those two things together. One of the most prevalent causes of death and one of the most preventable causes of death. Since we began operation, we've helped over 110,000 people. Our beneficiaries are the people of Ukraine. Any one of them might need us at any time. Наступний slide, будь ласка. Breaking down our work, this is an important thing because suicide prevention is the headline of what we do, okay? But the calls where there is an immediate potential risk of loss of life, that's about 15% of our work in total. Then there's another 25% of our work where we're dealing with what's called suicidal ideation. So where there's immediate suicide risk, that is a person who has made a plan to end their life. However, quickly they've arrived at that decision by going to a higher floor in the building that they're in, or having planned it out with medication or something like that. That is a person who intends to end their life and they still call us. And then the 25% who are experiencing suicide ideation, these are people who are beginning along the path of exploring the possibility of ending their life. And we help them to break that journey. So in total, while 15% are immediate life-saving calls, 40% of our calls are about suicide prevention. And then there's another 60%. And the other 60%, you know what? It comes from all kinds of different circumstances. And it could be, for example, relationship difficulties, right? It could be dependency issues, the issues with alcohol dependency or whatever else. And then another category of the calls, and I know I've told Yulia from IMC this story more than once, but another category of calls that we have is loneliness. People who are lonely make up about 8% of the workload of Lifeline Ukraine. We're simply being there for those people who might not have anybody else. This is the essence of the work that Lifeline Ukraine does, and this is why it's essential for every one of those 15% of the calls where we're saving a life in real time to those people who are lonely and rely on us around the clock. Будь ласка, наступного slide. The development of Lifeline Ukraine is something that I'm always quite proud of, and it's something that I want to touch on just very briefly. In previous presentations, we were looking at groups, demographics, who are at a potentially higher risk of suicide, ending their life by suicide, and that includes veterans, serving military, relatives of veterans, relatives of serving military. That's how we began. That's why we came together. That's what our first funding was for. It was to support veterans who've been fighting Russian aggression in the Donbass since 2014. We owe everything to those people and everything more to every single person who's been fighting for us since 2022 as well. But that's where we began. We began and we created a reputation amongst the veteran community that they knew that we were there to serve them. Many of my colleagues are veterans themselves because it began as a peer-to-peer support structure. But we always intended that we would be the National Suicide Prevention Hotline and Crisis Support Hotline for everybody in Ukraine, and particularly since the full-scale invasion, that's when we've needed that детальнейший наступний slide. More details in the next slide. This is how the volume of calls to Lifeline Ukraine has escalated over the last few years. I don't need to explain that much more. There was, again, reinforcing something that was said in an earlier presentation as well. We were looking at people who, because of the specifics of what Russia has done to Ukraine in this phase of the war, we're looking also at how we have to support people. So we've taken on expertise on how we support people who are displaced by war, just exactly the same as was being talked about earlier on. We've taken on expertise on understanding the specific challenges women face during war. And we also took knowledge from the best experts on how to support victims of sexual violence and how to support people who've been tortured in enemy captivity as well. These are the ways that the full-scale invasion has changed Lifeline Ukraine. And by God, I am so grateful that we have been there to do that, to play that role for this country. Next slide, please. Наступний slide, будь ласка. The next point that I wanted to come on to, and I'm coming towards the end of my presentation, is what can Lifeline Ukraine do for you, right? Our main mission, the top of the pyramid, is we reduce the number of suicides. We reduce the number of lives lost in Ukraine, not only in Ukraine, of Ukrainians. We also support people who are displaced overseas as well through chat functions. They're people who've also had a terrible literal journey and psychological journey as well. So reducing the number of suicides amongst the beautiful people of Ukraine, that's what we do, primarily through the hotline, but also advocacy and raising awareness as well. And this is really where we can interact, Lifeline Ukraine can interact with so many people who are on this call, advocacy and raising awareness, because many people are talking about training, and this is something that we have evolved into delivering more and more of over the last few years as well. Advocacy, challenging myths, addressing myths about suicide. We've been doing that since we began, but the training, наступний slide, будь ласка. The training is something that we've come into more and more. The logo there is IMC, and again, I'm going to use my example with Yulia. And when I was listening to Mariia speaking as well about training earlier on, the feedback you get, Mariia, from your training is, it was great, can we have more? That's exactly the feedback we got from our training as well. So what we've been doing is piggybacking, really, leveraging the work that other organizations have done. And I know Yulia for some time now, for a few years. And there are people that IMC interacts with, family doctors, psychologists, social workers, that they were meeting throughout the country, throughout the region, who are interacting, who are encountering people with suicidal ideation. And so at IMC's request, we went into the regions and we did in-person training. And just like Mariia, the overwhelming feedback that we got was, it's very beneficial. Can we have more, please? And so this is, the last slide was, what can we offer you? This is one of the things that we can do in partnership. And what we can also do as well is these training materials. Do you know what other organizations doing training? These training materials that we've individually collated, written, and are distributing. Let's have an exchange of information between us, just free of charge, just for us to improve yours, for you to improve ours. Why not? We're all doing the same thing. We all want to help the people of Ukraine. That's what we're here for. Наступний slide, будь ласка. Another kind of training that we've been doing, just really to finish this off, is talking to companies. And one of the things that I say to companies is nobody from their organization, be it from the warehouse floor to the boardroom, nobody's immune from these potential thoughts that we have, especially during this awful, terrible, awful, bastard war that we've been experiencing. Nobody's immune from this. So it could be anybody, specifically a group of people that we are helping as journalists. I myself am a journalist too, because journalists are not just covering a war, they're covering their war. And we also do a training as well on psychological resilience during wartime. The next slide, наступний slide, будь ласка. The next slide that we have is, I think, my online course that has been developed for anybody. So we're again talking about training. This is something that's aimed at lay people. There's a QR code there where you simply go to our website, Lifeline Ukraine, click the link that says training. And when I came into suicide prevention, I participated in a learning course from Canada, and then another one from the UK. And then a few years ago with USAID funding, we decided to create the same for ourselves in Ukrainian to educate everyday normal people on how they can have a conversation with somebody they might be concerned about. So that's something, again, that you can look at. Наступний, будь ласка, останній, я думаю, slide. What can we do together, potentially? I'm always on the lookout for current funding. Our future needs are to always be here. The partnerships that I'm talking about, helping each other, working together, coordinating trainings together, we can do all of those kinds of things. And should anybody know a donor who would like to support us, our social media work gets about 400,000 impressions on a monthly basis. So our donors are well rewarded in terms of the visibility of support for Lifeline Ukraine. Наступний, будь ласка, slide. Is simply my contact details, and thank you for your attention. I haven't kept time of this presentation. It was supposed to be 10 minutes. If it's 11, I apologize, but I hope I didn't bore you too much. My email address is there. My phone number is there. Anybody who needs to contact me may at any time, and I look forward very much to having further conversations with this wonderful group of people gathered today for this meeting. Thank you.
Величезне дякую, Поле.
Thank you so much, Paul. If I may, I'd like to say a few words to comment on your presentation and to thank you for such an important contribution to our discussion for the activity of Lifeline Ukraine. It's actually one of the organizations that in our technical working group chat, where there are so many specialists and non-specialists working in the area of mental health and psychosocial support, they mentioned Lifeline Ukraine the most. And I remember when there were some troubles in the work of Lifeline Ukraine, you received a lot of empathy and support, and kind of people worried, and the quality of support on this hotline is really impressive. So thank you so much for your presentation, and thank you so much for the spirit of cooperation, not competition, that in my opinion we have to promote, especially in these hard times when we have to support each other. Thank you so much for that, and we will share the contact information in the chat. And answering your first statement about the frustration about technical difficulties, let me remind you that we will have the recording of this meeting, and everyone who wants to watch it again will have a chance to watch it again. So everyone will have a chance to watch it. It'll be on YouTube, and we will share it, all the presentations. So we hope that not just the participants of this Zoom call, but everyone who wants will have access to this information. May I have the last word? I simply wanted to say that I cannot see in this group not even one competitor.
Чудово, дякуємо.
Great, thank you. Thank you. That is really impressive, and it's so nice to hear that. And thank you, and probably let's comment on the high level of the Ukrainian language that Paul has and the impressive support for Ukraine. Thank you, and we really appreciate that. And before I give the floor to Julia to sum up our meeting, I also want to give the floor to Moses. This is our second international expert. Yesterday, he read the webinar on suicide prevention for our technical working group. We will share the recording in the chat if you missed it, so that he would have a chance to comment on what we listened to today, and so that he would give us some feedback from the global level and maybe some recommendations. Moses, the floor is yours.
Thank you very much, and thanks for the invitation, and great to really listen in and listen to Paul, Claire, colleague we worked with before. But again, just to summarize, one thing comes to my mind listening to everyone is so the re-echoing of suicides being a public health concern. I would love to be to retaliate and say it's both a protection and public health concern. And this should be at the back of our mind, because then we need to see that the work we do in the mhPSS is not only seen at the clinical level, at the mhPSS level, but also be ingrained in the actions of the protection partners. And I think this also comes from the fact that most of the drivers of suicides go beyond our mhPCS domain to the work done in GBV prevention and response, child protection, community-based support services, and social welfare support. So, and again, in my final comment, I would say comprehensive suicide response and prevention requires multi-sectorial collaboration and multi-thematic engagement. Thank you so much, and really, this has been very fruitful, and thanks for listening to me. Back to you. Thank you.
Дякую велике, Мозесе.
Thank you so much, Moses.
Більше
Yes.
інформації, таких міжнародних настанов, більш
So more
практичних,
information, more
таких, що можуть
practical
бути корисні
guidelines
фахівцям,
that
що безпосередньо ведуть
can benefit the
клінічну практику.
specialists
Ми поділимося
working
записом
in the
нашого
clinical field
вебінару,
of
який
this.
відбувся
So
вчора.
for all of that, we
Юлія,
will
вам
share,
слово.
for clinicians, practitioners will share the webinar which we had yesterday. And Julia, the floor is yours. Thank you, Katarina. It was a very interesting webinar yesterday. I recommend it to everyone. To sum up, I'd like to say that it seems to me everything worked well. We worked very hard. We learned about the resources and the guidelines and the best practices from a few speakers. We heard about statistics data, and really, we have a lot to think about here, to reflect on. We learned about the plans and priorities of the state in the area of suicide prevention and about the importance of the primary healthcare specialists. And I think that a lot of the participants were really impressed, just like me and Katarina. We are so impressed every time when we meet with Paul. I can see that his Ukrainian is getting better and better and better, and I'm sincerely impressed. And the fact that Lifeline Ukraine is about the possibility to get support 24/7. This topic is very important. And it was in every presentation we heard about busting myths, advocacy, awareness raising. As Claire said, I think that it was in 2023, we had a webinar which Claire conducted on this topic, suicide prevention. And yes, it's been 2 years, but we still continue busting these myths, and this will really be very important work which will take not just 1 and not 5 years. So we all have to unite, coordinate our actions to bust all these myths, and then we will have a good and decent result in the future. Thank you so much for the participation. Let me remind you that the minutes of the meeting and the presentation will be sent to your to your emails. The recording will be on YouTube, and have a nice evening. Take care. Thank you, colleagues. Thank you. See you in 2 weeks.
Дякуємо, до побачення.
Thank you.
До побачення.
Дякую.